Yes, ma'am, we are live now, ma'am.
Yes, you can start.
Yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by Pinnacle News Series in association with Gaya, Sitamarhi, Solapur, and
Solapur.
Peruntalamana, OBGYN specialists. Yes, ma'am. So it's my privilege to introduce the MOC of today's webinar, Dr. Meenal Chidgupkar, ma'am. Ma'am is the IVF consultant at Apollo Fertility, Solapur, and also Dr. Chidgupkar Hospital Private Limited. Ma'am is currently the chairperson of Adolescent Health Committee, AMOX. I welcome you, ma'am.
Thank you. Thank you so
And
much.
it's my
Today,
yeah.
good evening,
Yeah. Let me
everyone.
introduce the other MOC, ma'am, Dr. Madda.
Sahiti, that's okay.
Yes.
Dr. Meena will be.
Smita is known to everyone, no problem. Meena, you can start.
Yeah, good evening, everyone. We are honored to have with us a very renowned gynecologist who has worked extensively in the field of women's health and adolescent health, dedicating her efforts in this for this important cause. This Pinnacle webinar series covers crucial topics and have a significant impact on women's health. Today, we are joined by esteemed societies from across India who will share their valuable insights on these critical subjects. Without further ado, I warmly welcome Dr. Sampath Kumari Madam to share her expertise and begin today's session. Madam is Foxy Vice President
Meena, okay,
2022.
okay. No, it's not a
Okay.
problem. Okay, Meena.
Yeah.
Thank you. Good evening to all. This is the Pinnacle series. Today's is the fifth series. We are selecting the societies all over India, north, east, west, and south. Today we have Sita Madi and um, Gaya from the east. Dr. Manju Sinha is the president and Dr. Poonam is the secretary of Gaya. Dr. Anju Singh and Dr. Lata from Sita Mahi Society. And from the west, we have Solapur Society, Dr. Neeta and Dr. Amrita, president and secretary. And from our south, we have Tirupur Society, that is the newly installed society, the president Dr. Punkode and the secretary Dr. Vidya. And Perindalmanna Society, president Dr. Mumtaj and Dr. Reshma. And we have our chief guest, Dr. P.M. Gopinath, who is a BC infertility specialist in all of South, almost. He is all over Tamil Nadu, and our guest of honor being Dr. Manju Sinha and Dr. Neeta. And we have the wonderful talk by Dr. P.M. Gopinath, sir, selection of IUI, and the panel discussion of ovarian simulation case scenarios, moderated by Dr. Kunju Moideen and expert being Pungodai. We have panelists Dr. Anju Singh, Dr. Srisha, Dr. Poonam, Dr. Amrita, Dr. Rishika, Dr. Lata, Dr. Reshma, and Dr. Vidyapar. And I welcome our MOCs, Dr. Minal and Dr. Madhumita for this program. Now we'll start the program with prayers. Yes, Sakiti.
Okay, ma'am.
Start.
Good evening,
Sir,
everyone.
Sir, 1 minute, sir.
yes,
We'll
sir.
start the
Yeah.
prayer song, then I will introduce you. Your TV is not
Okay.
at all projected, sir.
No
1 minute.
problem.
Okay, sir.
No problem. We'll go ahead.
Yes.
Good evening, everyone. I'm Dr. P.M. Gopinath, Director of Reproductive Medicine for the Kaveri Groups, former president of Oxy. I have been associated with Foxy from 1980.
Yes, sir.
So, and I have seen Sampath coming from Chengalpet Medical College with an undergraduation, coming for a post-graduation, and then doing her master's. And then she has got an excellent skills, and she's always been a pleasant, smiling for whatever issues she is facing. And she's a real, true team leader. She has involved in the Foxy probably much later in life, I feel, that she has come up to this level, and I wish her all the best and for further scaling into higher heights in Foxy.
Thank you so much, sir. Thank you, sir.
Welcome. I will just start off with my topic on patient selections for IUI. So, what is intrauterine insemination? It is
Sir, 1 minute, sir. Can you go for slideshow, sir?
Yeah, it is in the slideshow pattern only.
No, sir, it's not.
No, sir.
Maybe I'll
It's
stop and come
normal
back.
mode, sir.
Maybe I'll stop and come back.
Yeah.
Is it okay?
Yes, sir.
Yes, sir. Now
Double
it's okay.
click the slide, sir, so that you can.
Yeah. So we know the intrauterine insemination is an assisted reproductive technology which involves the deposition of the processed semen sample in the fallopian tube closest to the uterine cavity by overcoming natural barriers there. So, if you think in terms of the best quality of more motile sperms, we presume that they enter into the uterine cavity and then deliberately timed ovulation to get the effective fertilization. What are the prerequisites for IUI? We are going to talk about counseling on the success rates, ovulation induction, recommendations and use of gonadotrophins. We are going to discuss about choice of regimes and then luteal support. So it is in female factor, if you just say anovulatory cycles, maybe it is a previous ovulatory cycle or a timed cycles. We can just take it whether it is ovulatory or anovulatory, you can just take them for IUI. In case of endometriosis, it has to be mild or very minimal endometriosis. In severe endometriosis, where the tubal motility is altered, they may not be a suitable candidate for IUI. If you take the tubal patency, either one tube at least has to be patent, either by hysterosalpingogram, diagnostic lab, or sonosalpingogramming. The other factors, probably a vaginismus. Previously, the single partners, they were not allowed to do it, whereas today's ART law, a single female can go in for conception, whereas single male cannot go. So these are all the reasons. So if you look at the cervical factor, if there is a stenosis, stroma, or scarring, or if there is an antisperm antibodies, we can do it. Unexplained infertility, probably this is one of the common cause for an IUI, where all the methods have been failed, and then they come to us for this. The more important factor is the age. The age has to be between, the ART law specifies between 21 and 50. That's again very important. But over the age of 35, the result comes down, so we have to be very, very careful. When you evaluate the female partner, we look for FSH, LH, prolactin, TSH, and fasting blood sugar, ultrasound of the pelvis, and of course, anti-Mullerian hormone if you are going to use the gonadotrophins. The tubal patency by HSG or a diagnostic laparoscopy. HSG is a very, very simple thing which we can do, but always you should remember both laparoscopy and HSG are complement to each other. In case if you have a problem with the hysterosalpingogram, you have to do the laparoscopy to find out whether it is there. Or if there is a block by a laparoscopy, then you have to do the complementary, you have to do a HSG and try to do it there. So laparoscopy is again a gold standard, not only for the tubal evaluation. We will see the uterus, tuboperitoneal factor, uterus, everything can be done. So when do you do laparoscopy? When the woman is over 30, you can do. When they are married for more than 5 years, you can do. When there is a previous pelvic or abdominal surgeries, you can do. When there is an adnexal masses, you can do laparoscopy. when there is signs and symptoms of endometriosis, you can do laparoscopy. Otherwise, for all patients, you can just go in for hysterosalpingogram. It requires, admission, anesthetic procedures, and then it has to be an inpatient. But there are some small things which the complements are lysis of additions can be done, minimal diagnosis and excision of the endometriosis can be done. You can do a myomectomy, and then you can do tubal constructive surgery along with this. This is the in thing today. It is a anti-Mullerian hormone. It is a dimeric glycoprotein. From the small pre-antral and small antral follicles, it is being secreted. It indicates the ovarian reserve. I always tell the patient, it is something like your bank balance, how much of money you have. You do an AMH, you will be able to find out what you can do. The decision regarding the fertility management, for example, a 27-year-old woman with both the tubes patent, when comes to you for a IUI, you do an ovarian reserve testing when it is about zero point 0.8 AMH, you do not waste time, directly you go in for IVF. The same way, 35-year-old lady who comes to you for an IVF, she has got a very good ovarian reserve, both tubes are patent. You can give a sample of 1 or 2 cycles of IUI, failing which you can take the patient for IVF. So all this decision will be dependent on AMH level. Coming to the male factor, azoospermia, probably we go in for a donor insemination. Oligoastinospermias, mild and severe, where when the total motile count is less than 10 million, you can do it. If there is a penile abnormalities, retrograde ejaculation, erectile dysfunctions, you can go in for an IUI. Unavailable partners, where they are working abroad, they give a sample for freezing and then go, then you will be able to do that. Inheritable genetic disorders and serodiscordant couples, you can just do the IUI. So the most fundamental test sensitive in male factor is only a semen analysis. So it counts for about 40 to 50% of this infertility. And when you do an essay interpretation, you look for concentration, motility, and morphology. So there are a lot of parameters are there. It all goes by the WHO criteria. So outline based on the sample. If it is a normal concentration and motility, you do a ovulation induction and normal contact. Concentration is between 10 and 16 million. You go for a superovulation and IUI. Concentration is less than 10 million, especially less than 5. You're going for a controlled ovarian stimulation with IUI. So this is the parameters with which you just try to just do that procedures. What is the approach there? So step 1, assess the age, BMI, years of infertility, and AMH. Step 2, assess the tubal factor and male factor. Based on this criteria, you can decide whether to go in for a IUI or IVF there. So how do we do the ovulation induction? There is lot of follicles are there in the early follicular phase. When in the mid follicular, one becomes dominant. Late follicular phase, only one comes out. So this is a single follicle, monofollicular development, naturally occurring in a spontaneous cycle. If you look into the IUI, we aim at the mid-level, put a little more of an effort in the form of an external medications and make sure at least 2 to 3 eggs comes out. This is the difference between the ovulation induction in a spontaneous cycle and then in the single. How do we do it? We can combine the gonadotropin for IUI therapy. We can reduce the cost of gonadotropin. See, normally we use letrozole, 5 milligram from 3rd day to 7th day. When you combine the gonadotropin, the success rate goes up. It reduces the gonadotropin in single. There is no anti-estrogenic effect on the endometrium. It is a higher pregnancy rate, cost-effective, low OHS, and low multiple pregnancy rate. So this is how some of the samples, clomiphene plus metformin in IUI PCO patients from 3rd day to 7th day. FSH or HMG, we start with either 75 or 150, depending upon the age, previous response, and AMH on 6th day, 8th day, and 10th day. And then you do the follicular study and then decide on the further thing. How do we monitor? We monitor by a follicular tracking from second day onwards. Second day, you look at the ovarian volume, look for the antral follicular count, and then how it is in relation to the uterus, shape, position of the uterus, endometrial thickness, and see whether the sliding sign in the pouch of Douglas fluid, whether it is freely mobile or adherent there. In the proliferative phase, you look at the endometrium, it will be something like a 3-layer. Very easily, you will be able to see it there. And at the same time, you look at the follicles will be growing. This synchronicity should be there between the endometrial thickness development and follicular development. So that is very, very important. At the time of ovulation, you will see the endometrium completely becomes homogenized. It is converted into a secretory endometrium because of the follicular fluid will be there in the pouch of Douglas, and then there will be a shrinkage of the follicle, what you have seen in the previous slides, round one, which will become slightly irregular now. We have to choose a trigger for follicular rupture. The best choice of the trigger, the best timing of the insemination, is it double or insemination is needed? These are all the important events which we will see. HCG is probably one of the best common triggers when it is being used. If you use an HCG trigger, you will see here it has got a prolonged activity where it will rescue the corpus luteum and give you a little bit of the luteal support. The drawback is if you hit more number of oocytes, it will go in for an ovarian hyperstimulation there. So once when you prepare that, all you have to do is gently put the catheter close to the fundus and then inseminate a small amount of fluid there. The prepared sample will be injected there. That goes into the fallopian tube, and the mid fallopian tube, they meet the sperms and then get fertilized there. There has to be a time interval between the sperm preparation and incubation. Usually, you should not cross more than 60 minutes, ideally 30 minutes. Avoid segmentation. Doing it in one place, bringing to the other place should be avoided. If you don't have a facility in your place, please go to the place where there is a facility. You go there and then you do it there. So that is the most important thing. The success of this IUI depends upon the patient selection, which will be age, BMI, marital years, and patency, and the previous responses there. Again, depends upon the stimulation, drugs, monitoring, timing, and method of ovulation. Then it also depends upon the semen concentration, motile sperms, and then semen preparation methods. And then again, last but not the least, the luteal support, which is necessary. So in cycle 1, it will be better, and then gradually it will increase it, but it never crosses the 3rd cycle, and cumulative pregnancy rate after 3 cycles will be only between 15 and 20% there. How does the failures occur? It is probably because of the poor patient selection, improper timing of the IUI in relation to the ovulation, poor semen preparation, and then faulty techniques or a difficult IUI, and subtle tubal dysfunctions or peritubal adhesions, poor quality oocytes, non-receptive endometrium there. So with this, we are going for the luteal support. We can give the progesterone in the form of an intramuscular, per oral, or PV there. Today, probably the PV is the most accepted form, but however, some people will have hesitation. The oral application of the progesterone is equally effective, and then the IM is, even though it is effective, the patient is reluctant to take 14 injections every day. If you look at the meta-analysis of an IUI for a male factor, timed intercourse gives you about 2.4%. When there is a controlled ovarian hyperstimulation with timed intercourse, it becomes 5%. IUI in a natural cycle is 6.5. IUI in a controlled ovarian hyperstimulation is 12.6. This is the reason why we always have to choose for an IUI controlled ovarian, whether to do a single or a double. So they have just given, there are a lot of things which some of the papers show. There are 5 trials involving this 11,125 IUI cycles were included in the meta-analysis. You will see that there is definitely an appreciative level, but however, most of the things are favoring you will see that the diamond shape is more or less touching the midpoint, that shows it is insignificant there. How to process the semen is again important. Swim up technique or a wash, what culture medium to use, whether to use a Hippies buffer, can we add pentoxifylline to improve the motility, gradient density centrifugation, or what is the motile sperm count after the thing, what is the volume. These are all the queries, but it all depends upon your embryologist and available techniques with whom the embryologist is very familiar with. You can choose volume. Of course, it's only about some 0.2 to 3 ml. What are the catheters we use? There are soft catheters, they are rigid catheters. Ideally, the soft catheter is fine, but if you have a cervical issue, you should have a standby of a rigid catheter there. So does this brand matter for an IUI, whether it's the foreign India? All of them are more or less same there. The location of the catheter, the catheter tip has to be about 1 centimeter below the fundus. Is there a bed rest necessary after an IUI? Absolutely no. Even after an embryo transfer, we allow the patient to walk easily. That the patient, if you have to optimize the IUI success, you have to do the patient selection. It should be less than 35 years, less than 5 years duration. Cause of fertility, there has to be a minimum 1 functional fallopian tube, no uterine factor. There has to be an adequate ovarian reserve. And that timing, it has to be between 12 to 16 hours of the cycle. Usually the highest pregnancy rates will be there. And when there is an interval between this HCG injection, it used to be 32 to 42 hours usually recommended for a single insemination. Single 36 hours is usually commonly practiced. Even we practice the same there. Semen sample quality and expertise of the lab personnel is very important. Procedure IUI, the type of the catheter used to be, as I said, soft catheter. Luteal support is indicated when you get more than 2 follicles developed there. How many cycles you can do? Usually, as I mentioned it, there is a plateauing of the success rate after 3 cycles. If the facilities are available, if the patient can afford, please refer them to IVF after 3 cycles. If they cannot afford, or if there is no facility in your area, probably you leave a gap for about 1 or 2 months, again continue for about maximum 6 cycles there. So this is, you see the number of patients taken in this trial at the age group, and you look at the pregnancy rate. When the patient is less than 24, pregnancy rate is about 19.6. Whereas when the patient is more than 43, the pregnancy rate falls down to 3.4. Age is one important criteria to have a good success rate. This is another tablet which I have formed it. This is this shows the count of the sperm. Less than 1 million, 1 to 5 million, 5 to 10 million, 10 to 20, and above 20. This is the timed intercourse, but this is the success rate percentage of pregnancy. When you do an IUI, this is the pregnancy rate. And when you do a controlled ovarian stimulation in IUI, this is the pregnancy rate. So probably in my center, when we do a controlled ovarian stimulation for a good count, I can expect about 10% on the first cycle. So cumulative on the second and third cycle might go up to 20. So you have to prepare this chart as per your thing. Where do the success takes place? 15% of the women when it is less than 30, 12% when they are 30 to 35, 7 to 8% when they are 35 to 39, less than 2% over the age of 40. So ideally, 7 more than 35, you prefer to do an IVF rather than wasting time on IUI and repeating it. So in nutshell, it is a very simple procedure. It is a safe procedure. We have to carefully select the patients and do the procedure with stimulation, with gonadotropin to get the optimal results. Thank you very much for your patient listening.
Thank you so much, sir. In your busy time, I thought after addressing the chief guest, he has given his lecture. Dr. Mumtaz, are you there?
Yes, ma'am.
Yes.
Thank you, Gobinath sir, for that. I must say it was like watching a movie, how beautifully you had explained the IUI and the preparation that is required before that. Beautifully narrated, and also the importance of looking into the endometrium, the sliding sign, and how the ovarian follicle development. And also, you conveyed a very important point that we shouldn't be wasting too much time on keeping on doing IUI. Maybe after 3 cycles, we have to reconsider the choices and refer the patient to a IVF center, especially if the age is also going up. So, and also you have beautifully shown us the important aspects that we have to look into when you select a patient for IUI, and what are all the determining factors which is going to affect our success rate. Thank you so much, sir.
Thank you. Thank you.
Thank you, sir. If time permits, we can continue, sir, here. Now, next we will be having our guest of honor has to be. Thank you so much, sir. Dr. Meenal, can you
Yes,
introduce
ma'am.
our guest of honor? Sir, Gopinath, sir, thank you for being the chief.
Thank you. Thank you.
The first talk. Thank you so much. Yes, Meenal.
Yeah.
You can introduce Dr. Manju and
Yes, ma'am.
you are muted.
Yes, ma'am. Introduce, madam. I will call Solapur OBGY Society President also.
Okay, no problem. Now we have Dr. Manju Sinha, who is our guest of honor. She is the president of Gaia Society. I invite her to give few words as the guest of honor for the success of this webinar. Dr. Manju, ma'am.
Yes, ma'am.
Yes, Dr. Manju.
How about check to her? Yes, ma'am, I'm here.
Yes,
Yeah.
you can tell few words as a guest of honor.
Yeah. I'm from Gaya, Magadar of Technical Society president since 2 years. And I've not sent a whole CV. I've done MBBS from the Lady Harding Medical College, Delhi, and MS and DGO from the PMCH Patna.
Yes,
I'm practicing since 40 years in Gaya.
yes. Thank you so much, Madam Manju, for being the guest of honor for this webinar. Dr. Minal?
Ma'am, she's not picking up the phone. Maybe she will be busy in
Yes.
some.
When she joins, we can get the blessing.
Yes, ma'am.
Now
Yes.
we can go with the panel. You can introduce the panelist. Dr. Kunjumaidin sir is here, no?
Yes, ma'am. Sir is there, ma'am. Sir is not renamed. Sir is there.
Yes. Dr. Minal, you can start introducing the moderator, expert, and the panelist.
Okay, thank you, ma'am. Our second session is panel discussion, ovarian stimulation, case scenarios. The moderator will be Dr. Kunju Moidin, who is like immediate past president KFOG, medical director Birla Fertility, ARMC IVF, past president Perithal Manna OBGYN Society.
Yes, ma'am. Welcome, sir. Kunjumaidin.
Welcome, sir.
Yes, he is there. Yes, Minal, you itself can introduce all the panelists and
Okay, ma'am. Okay. Now our esteemed panelists are Dr. Pungothai Selvaraj, who is a gynecologist, laparoscopic surgeon, Managing Director, Divya Hospital, Bhavya Fertility Center, Tirupur. She has done MD from Coimbatore and founder president of Tirupur OBGY Society. Her field of interest are ART, operative laparoscopy, hysteroscopy, and high risk obstetrics. Our second panelist,
Pungode madam is an expert. Others are the panelists. Okay.
okay, expert. Our Dr. Anju Singh, madam, she is director, Baijnath Nursing Home and Research Center, founder, vice president of Sita Marthi OBGYN Society, at present president of the same society. She is life member of Indian Association of Gynecology and Endoscopy, ISOPAB. She has organized various workshops at Sita Marthi, and she has a special interest in high risk pregnancy, infertility, and endoscopy. Sheshta Iqbal, she is a senior resident at OBGYN Gaya. She is consultant gynecologist in Gaya, Bihar, and member of Magad OBGYN Society. Dr. Poonam Sahai, she is secretary MOGS Gaya. Amrita Mishra, she has done DNB OBGYN, MS OBGYN, and currently working as senior medical officer at Sadar Hospital, Sita Marthi. Dr. Vidya Prem R. She did her UG in Madras Medical College, PG in Kasturba Medical College, Mangalore, completed her DNB, her fellowships in fertility from Simar, and practicing OBGYN and fertility work at Tamaraj Fertility Center, Tirupur. Dr. Lata Gupta, she is consultant at Lata Nursing Home, founder secretary at the Sita Marthi Obstetrics and Gynecological Society. She is past president Lions Club Sita Marthi Priyadarshini and life member of ISOPAB, IMA and Red Cross. Dr. Pratibha Baldava, she's from Solapur OBGY Society. She is obstetrician and gynecologist and fertility consultant from SS Baldava Hospital, Solapur. She has done many national and international papers and received many prizes at various conferences and awards in AMOGS 2023 also. Dr. Reshma Sachan, she is secretary, Peritelamanna OBGY Society. Dr. Rishika Singh, she is a dedicated and compassionate gynecological surgeon with profound commitment to delivering exceptional patient-centered care in order to contribute well-being of patient and community. She has done her MBBS from Manipal and MS from West Bengal, and she has done a fellowship in minimal access surgery and hysteroscopy. Ma'am, you are mute.
Yes. Yes, Doctor. Kunjumaidin, you can start. All the panelists are there. All of them are there.
Yeah. Good evening, everyone. I request someone to share the
Yes,
PPT.
Sakiti?
Yes, ma'am. I'll start, ma'am. Just.
Yes, you can start. Her laptop has some problem, I think. He was telling. Welcome, Dr. Kunjumaidin.
Yeah. Good evening, ma'am.
Kunjumaidin is going to contest for Clinical Research Committee.
Yeah. I request everybody's blessings.
Support.
Best wishes, sir.
Yeah. Thank you. So we will straight away start with the case presentation. So here, because today the ovarian stimulation, the basics of everything, Dr. Gopinath has already mentioned. So we will just quickly go through the cases so that we'll have more time to discuss rather than to discuss a lot of theories. So here is a patient, 29 years age. I think everybody has to carefully look at this slide because we will not come back to here again. At 29 years age, 24 BMI, oligocycles since menarche, infertility for 2 years, semen analysis normal, and AMH is 3.8, AFC 20 bilaterally, antral follicular count, tubes are patent, baseline ultrasound is showing endometrial thickness, and she had history of 3 previous cycles of ovulation induction with a clomiphene citrate, but no pregnancy. Next slide, please. Next slide. Yeah. So the clinical dilemma is how to optimize ovulation induction to improve pregnancy chances. Actually, all the panelists need to help me to clear these dilemmas so that it will be useful for all the audience. How to optimize ovulation induction to improve pregnancy chances. Is there a role for IUI or should timed intercourse again is sufficient? Or what should be the next steps if this cycle fails? Next slide. Next slide, please. So, request someone to explain basically. So, this is the basis of today's discussion for this case. Who is going to tell me? Dr. Poonam, you are here. Dr. Poonam. Dr. Shaista, you are here.
Yes, sir.
Yeah, kindly explain.
Yes.
You are Poonam or Shaista?
So myself, Shaista Iqbal from Gaya. Good evening.
Yeah. Okay. Good evening. You please just tell us in a brief, simple way the classification of an ovulation because that is the basis of discussion of ovarian stimulation case scenarios.
Yes, sir. So first it starts from the hypothalamus and GnRH, and then it releases FSH and LH just from the ovary, and then it acts on the it releases the estrogen, and then that works, and then the menstruation occurs. So if there will be anovulation, sir, and the ovulation will not occur, then in PCOD mostly there is an anovulatory cycle. So the case you discussed, in that there was a scenario like there was first timely intercourse was taken or not. We have to see in that. Then transfollicular monitoring should be done on day 12, day 16, and day 14 to see whether there was ovulation or not after giving the clomiphene citrate. And then if there was ovulation, then there was rupture of the ovulation, rupture of the ovum or not. For that, they had to give the SCG injection. So after doing the TBS follicular monitoring.
Yeah, here Shaista actually, they are trying very hard, having even intercourse twice a day, and the ovulation was demonstrated all throughout the 3 cycles of clomiphene.
Yes, sir.
Okay, next slide, please. Next slide. Next slide, please. Yeah, we need to mimic single follicular development in natural cycles in ovulation induction. So one more click on the slide. So we have one more text box will come. Yeah, this is basically the how an ovulation mature follicle is being developed based on the estrogen feedback, then FSH secretion, which is limited by, again, the produced negative feedback from the estrogen produced by larger follicles. Smaller follicles with fewer FSH receptors no longer stimulated to grow, decreasing FSH levels. So basically, this is the basic diagram which is showing how a single monofollicular development is being developed. Next slide, please. Next slide. Somebody has to quickly move the slide. Yeah. So this is the anovulation. Yeah, this is the anovulation in PCO patients. So basically, there is supraphysiologic synthesis of estrogen, strong negative feedback signals to hypothalamus and pituitary, low GnRH production with positive feedback on LH, low FSH and high LH. So ultimately, this will result in very small follicles and next slide. So who is going to tell me? Dr. Leda Gupta, can you tell the mechanism of action of clomiphene citrate in a small way? Dr. Leda, you are there?
Dr. Vidya, you can call her Dr. Vidya.
Dr. Vidya? Dr. Vidya? Dr. Vidya, you are there?
Yes, sir, I'm here.
Yeah. Please,
Yes,
please
sir.
teach me. Please teach, not only teach me, teach us the
Yes, sir.
ECC
Sir.
mechanism of action.
Yes, sir. Clomiphene is a selective estrogen receptor modulator. So it acts on the central estrogen receptors, central nuclear estrogen receptors.
Yeah.
Clomiphene occupies the central estrogen receptors, and so that the peripheral estrogen is perceived low, and therefore gonadotropins are secreted.
Yeah,
This helps
basically
in
it is an
development of the follicles.
yeah, basically it is an anti-estrogen, isn't it?
Yes, sir.
Next
Yes.
slide, please. Next slide. So Vidya, you just tell what are the anti-estrogenic effects of the that picture is not coming, I think.
Yes,
What
sir.
are the anti-estrogenic effects of
It
clomiphene?
causes endometrium does not grow well. It causes thinning of the endometrium. It causes
Plus,
thickening of cervical mucus.
yeah.
Thereby preventing the affecting the sperm motility upwards, ascending of the sperm.
Yeah. So changing the quality and quantity of cervical mucus and changing the quality of the endometrium, isn't it? Basically, in spite of having the ovulation happening, the pregnancy may not happen, basically because of this reason.
Yes.
And also tell me how many cycles and how long you will continue with the clomiphene treatment. Why I'm asking this question is to know, is there any need to switch over from clomiphene to any other drug in the particular patient? So we should have a clear idea how many cycles we can give and how long we can give.
Generally, I start with 100 milligram of clomiphene from day 3 to day 7, and follow her up. A maximum for 3 to at the max 6 cycles I can go.
Yeah.
If she doesn't ovulate or doesn't get pregnant, then I have to shift to the next ovulagen.
Yeah, basically 2 to 3 cycles with the same dose. If ovulation is happening, better to skip it and change over to next line of drugs or troubleshoot, isn't it?
Yes, sir.
Yes. So there is something like CC resistance and CC failure.
Yes.
So in very simple way, just click again, it will show the CC failure. Yeah. So to understand it better, CC resistant, no ovulation. CC failure, no pregnancy. So this is the two different things. Next slide, please.
He finished.
Next slide. Yeah. So this is a algorithm of planning of CC resistant PCOS. So you have to decide between obese and non-obese. Non-obese, the obese, of course, the lifestyle modifications has to be there to reduce the body weight and the better response for your ovulogens. And non-obese, of course, you can add the adjuvants and think about adding gonadotropins or change the ovulagen. Next slide. Yeah. So, Dr. Anju Singh, you are there? Anju Singh?
Kunjumaidin sir, you can ask Dr. Pungode madam. I think the only Vidya Prem Pungode madam and Sesta is there.
Okay. Dr. Pungode, can you just tell? Yeah. Good evening, ma'am.
Good
Back
evening,
again.
sir. Good evening, sir.
Back again in a different format. So
Yes,
just tell
sir.
me or just enlighten the audience regarding how letrozole act. Yeah, please. Yeah, it is there in the slide. You can just summarize it.
Pungode madam.
Letrozole is aromatase inhibitor. Am I audible, sir? Am I audible?
Yeah, audible.
So
Yes, ma'am.
letrozole is a drug of choice in ovulation induction in patients with PCOS. It acts by inhibiting aromatase inhibitor enzyme in the granulosa cells. Thereby it prevents the conversion of androgen to estradiol. So there is a decrease in estrogen level. So the the hypothalamus pituitary axis, it gets relieved from the inhibitory effect of estrogen. So the secretion of FSH and LH, FSH is increased. So thereby it causes follicular growth and ovulation.
Yeah. So next slide, please.
Yeah.
Next slide. Yeah. So this is the basic difference between the clomiphene and letrozole. Clomiphene is a very well. Yeah. Please enlighten us.
Clomiphene action is prolonged, so it causes complete blockade, depletion of estrogen receptors in the hypothalamus and pituitary hypothalamus. So there is prolonged action of FSH. The secretion of FSH is more, so it leads to multifollicular formation. But in case of letrozole, as it is short acting, the half life is only very short, so the FSH level decreases and it leads to only single ovulation, mono ovulation.
Yeah, so basically it will result in a monofollicular development. Monofollicular development. Next slide, please. Next slide. So basically the advantages of letrozole over CC. Can who else can enlighten us? Dr. Pratibha? Dr. Pratibha, can you just enlighten us on this part? What are the advantages letrozole have over clomiphene citrate? Yeah, Dr. Pongade, can you just highlight? Yeah.
Letrozole has the half-life is only 5 to 7 days. 45 hours. Sorry, the letrozole half-life is short, but clomiphene citrate is a long half-life. So the anti-estrogenic effects of clomiphene is more. It is on thin endometrium, and also it causes thickening of the cervical mucus. But in case of letrozole, it favors endometrium, and also it is favorable for cervical mucus. And uterine artery blood flow is increased with letrozole and decreased with clomiphene citrate. And risk of miscarriage is more with clomiphene and less with letrozole. And OHSS risk is also high with clomiphene compared to letrozole. And letrozole chance of multiple pregnancy is also more because of multiple ovulation in case of clomiphene when compared to letrozole.
Yeah, so the standard dosages of letrozole that can be escalated from cycle to cycle depending on the response. So what are the different dose regimes of letrozole? Who is going to tell me? We'll be back to Shaista again.
Yes, sir. First, sir, we start with a very small dose, 2.5 milligram only. We give from day 3 to day 7. And similarly, we do the previous follicular monitoring and we see the ovulation has occurred or not. If the ovulation does not occur, next cycle we increase the dose up to, we'll increase 5. And then again, we'll do the follicular monitoring. If it does not happen, then we give 7.5 milligram day 3 to day 7 in the third cycle, sir. And if ovulation occurs, then we continue. We'll see accordingly.
Yeah, got it. So it can be even a single dose regime or it can be the conventional regime. The previous slide, please. Previous slide. Next slide. Next slide. Yeah. So this is the conventional protocol, what we all follow very regularly and commonly. The next slide. Yeah, this is something different one. 20 milligrams simultaneously you can give as a single dose protocol. But personally, I'm not being used to it. But generally, it has been described in the literature. Do anyone do give 20 milligrams simultaneously in the panelist? Do anyone have that experience? No. Okay. Next slide. Next slide. Next slide. So there is something like superovulation for protocol for IUI. Here again, letrozole 5 milligram day. It is always better than produces more follicles rather than the 2.5 milligram, 5 milligram dosage. Okay, next slide. Next slide. Then high dose protocol, that is 7.5 milligram per day. 7.5 milligram per day from day 2 or day 3 for next 5 days. Then give HCG to trigger and follicle more than 18 millimeter. Next slide. So what are the options in case of letrozole resistance? Who is going to tell again? I think I'll catch hold of Dr. Pungode again.
Dr. Vidya is there, sir.
Dr. Pungode again.
If extended letrozole or stair-step protocols are followed and we don't get result, then we can combine them with gonadotropins.
Yeah, can
We
you
can
just
use
tell
extended
extended
letrozole
protocol or stair-step?
Stair-step. If these fail, we can add
Yes.
gonadotropins to letrozole. Gonadotropin is again, it is a recombinant FSH. We can start with a small dose like 37.5, and it is a chronic low dose protocol. And we can give for 15 days like that till we get a good follicle. Suppose if there is no follicular development, we can increase the dose step by step with 37.5.
Next slide.
Kunjumaideen, sir, next slide or this slide you want to discuss?
Yeah, 1 second. 1 second. Yeah, this slide only, extended protocol from day 1 to 10. That is extended protocol. It is compared to short letrozole protocol. The long protocol is associated with higher pregnancy rate. Basically, letrozole without anti-estrogenic effect produces more follicles in this case. But generally, in our routine, regular practice, after the initial 5 days of letrozole, we generally add gonadotropins. Next slide, please. Next slide. So this again, same thing, 2.5 milligram to start with from day 1 to day 10, and 1 follicle more than 18 to trigger the patient. Next slide. Yeah. Dr. Pongode, just tell us this this stair-step protocol, briefly explain to the audience.
This is, first we start with 2.5 milligram of letrozole from day 2 to day 5, day 7. Then we have to see the response. If there is no follicular formation, then we can increase the dose to 50 milligram. Again for 5 days, then we have to look for the follicular formation. Suppose if it is not there, then we can increase further to 150 milligram for 5 days. So this is a step protocol.
Okay. Do you do anyone use this protocol again? So
No,
basically, basically whatever said and done, we need to be very sure about the time to pregnancy rather than trying on things what is there in the literature. Very often we fail to implement it. Next slide. Yeah. Here again, letrozole, again CC, all those things, combined protocol, CC plus letrozole. Next slide. Next slide. Yeah, this is letrozole or clomiphene citrate plus gonadotropin. Just exactly what Dr. Pongode has mentioned, to have the letrozole initially. This is the typical thing what we follow, either letrozole or clomiphene in the beginning, then add with gonadotropin. So this is one of the strategy for the clomiphene resistance as well as the letrozole resistance. So this is another way we start gonadotropin along with letrozole. Next slide. Again, minimum dose stimulation protocol. This is again, which we use very often in the donor cycles. Who is going to describe about it? Dr. Shaista, can you just explain about this protocol? Yeah, you can just go through it and just explain to us.
Yes, letrozole 5 milligram is given from day to day 6. And on the day 3 of the letrozole treatment, we give the low dose gonadotropins at 150 units daily was initiated. And then GnRH antagonist was introduced when one or more follicles reached 14 mm or larger. versus high dose stimulation protocol like is gonadotropin greater than 300 IU per day through the antagonist cycles.
Okay, next slide, please. You can delete it. Next slide. Yeah. Then again, CC plus gonadotropin, which we described earlier. CC can be given in the dosage of 100 milligram per day for 5 days. Then gonadotropin to start with. Basically, I don't go for 37.5 and all. I generally start with 75 milligram of gonadotropin, mostly HMGs, then escalate it according to the response. Next slide, please. So again, injectable gonadotropins. Okay, Vidya, you are there, Dr.
Yes,
Vidya?
sir. Yes, sir. Yes, sir.
Yeah. Please tell us.
So after starting with the Letros for 5 days, then along with that we start FSH. Maybe around, I usually start it at 75 international units daily for 4 to 7 days based on the follicular development.
Okay. So based on the follicular development, we go ahead with the escalation of the dosages. But here, strictly, we have to monitor the cycle because to avoid the hyperstimulation, because it is going to be either the time to course or the IUIs, isn't it?
Yes, sir.
Next slide, please. Next slide. Next slide, please. Yeah. Again, these are some of the theoretical ones which have been described, but what we generally follow is the step-up protocol, like what we have mentioned, 75. It can be 150 or 225, and the maximum dose in a conventional IUI cycle can be 225, but still we should be able to increase it. Yeah. What are the role of adjuvants in ovarian stimulation? Next slide. Next slide. Anyone can take up. I think only 3 of us are here. Please.
Yes, sir. In PCOS, we use metformin as an adjuvant.
Yeah. Then
there is hyperprolactinemia, then cabergoline or bromocriptine.
Yeah. Next slide, please. Next slide. So metformin, it is also not recommended as the first line medical thing, but it can be combined along with the adjuvant. But it is recommended to do at least OGTT when we use metformin. What are your experience with a lot of other things are there? Decairo, inositol, myoinositol. So what are your experience? I look forward to hear from all of you.
I generally use metformin with inositol for all PCOS patients.
Yeah.
As an adjuvant.
Okay.
And I also use DEXA in severe PCO.
Yeah.
Dexamethasone 0.5 mg.
Yeah.
I started with stimulation until I get a dominant follicle.
Okay, next slide, please. We have something interesting on that about that. So, yeah, you can keep on clicking till the slide is full. So minoxidil and decairoinositol are indeed different modules. Earlier, it has been considered as the food supplements. Now, a lot of studies are coming up, whether it is it can be utilized and its efficacy is coming up in a big way. But the disadvantage is that it has to be used in a large quantity, then only to be effective. Next slide, please. Next slide. Yeah. Do we have time?
Yes, sir. Yes, sir. We have 20 minutes.
Yeah. So here, just a moment. Yeah, here it is a case of 38 years woman. She's thin, slim, regular cycles, infertility for only 3 years, but she already had two failed IVF cycles with poor response. And is low 0.6. AFC is again low 3, both sides together. FSH day to FSH on the higher side, and coupled male factor is normal. Next slide, please. So again, there are a lot of dilemmas associated with this patient. How to optimize ovarian stimulation in a poor responder to maximize oocyte yield, which is best suited. Is there role for adjuvants? And would embryo accumulation and PGTA improve the outcome? Next slide, please. Okay, so we are not going into the details of the poor response, which we already discussed last week. So basically, can someone tell me what is the Bologna criteria and what is the Poseidon criteria, the differences and the efficacy, means the utility wise? Can you just tell me?
Bologna criteria is by ISRE consensus in 2011. It includes advanced maternal age more than 40 years and previous poor ovarian response if the oocyte yield was less than 3 and abnormal ovarian reserve test. The AFC is less than 5 and AMH is less than 1.1.
Yeah.
And another criteria is Poseidon criteria.
Yeah. Yeah. Next slide, please. Next slide. Yeah.
So
Yeah,
the
please.
Poseidon criteria, group 1 and 2, these two classify patients with unexpected poor response. And if the age is less than 35, it is group 1, and age is more than 35, it is group 2. Here, the ovarian reserve tests are normal, but the patient used to show unexpected poor ovarian response for conventional ovarian IVF protocol. But in Poseidon group 3 and 4, already the patients have reduced ovarian reserve.
Yeah, basically here two groups. We need not even tell 4 groups. 2 groups. One is on the one side, 2 groups are the expected poor response. On the other side, 2 groups are the unexpected poor response, isn't it? Next slide.
Yes.
Next slide, please.
Sahiti, next slide.
Yeah, so basically the ovarian tests can be differentiated into the dynamic tests as well as the laboratory tests. Dynamic tests are something like you look at the ultrasound and say the antral follicular count, and the biochemical test, the most important is the AMH. Sir has specifically highlighted on that, so we are not going to the details. Next one. So the combination of biochemical tests at which all stage it is useful. AMH can be done on any day of the menstrual cycle, but there you can expect a lot of variations depending on the assay methods. And AFC is the dynamic one. And again, the treatment regimes, it can be either high dose protocol, antagonist protocol, natural, or with adjuvants. So next slide, please. So, Shaista, just tell the importance of synchronization in the ovarian stimulation and the protocol.
Sir, first synchronization. Firstly, when we start with the lateral route, sir, we have to also see when we do the TVS, sir, we also see the endometrial thickness, sir. If the endometrial thickness is not compatible, then also ovulation will not occur. Like shown here, that endometrial 0.1 milligram was here. And sir, GnRH antagonist also plays a role, and FSH and HMG can be given, sir.
Okay. So it can be FSH or recombinant FSH or HMG. So what do you say about the high dose ovarian stimulation protocols, high dose gonadotropin to start with in poor responders? What is your dosage regime to start with in the
So
beginning?
with FSH 300 to 450 IU per day, we start, sir. FSH plus recombinant LH. And then we low dose SCG supplementation is added. So pure SMG as shown, so FSH plus
Yeah,
SMG is started.
yeah, that's great. So we can even start. What will be the maximum starting dose which you can give it off?
Up to,
So max
up to
200 to
450.
Yeah. Generally, personally, I don't go beyond 300 to start with. But of course, we can escalate in between the after 5 days of the stimulation because the outcome has been almost similar. That's why the concept of minimal stimulation, however much higher dose you give, the output may be 1 or 2 oocytes. That's why the concept of minimal stimulation and take out the oocytes with the lower dose possible and then cumulate it, isn't it?
Yes.
So agonist and antagonist protocols can be equally applied, but more often we prefer the antagonist protocols. Next slide, please.
Sir, in Hoover Reserve also agonist protocol is preferred or antagonist, sir? In Hoover Reserve,
Antagonist is preferred, but the agonist, various types of agonist protocols also can be done. That's why here it is given. A flare protocol. It can be the short protocol or ultra short protocol, where we utilize the stimulatory effect of the agonist also during the stimulation cycle. And the advantage of this protocol is that we can do the fresh embryo transfer. See, there is no point in keeping lot of blastocyst and the time to pregnancy is being delayed. Rather, you do a fresh transfer and reduce the cycle cost and take the advantages of the the vitrification, thawing, and the resultant damage to the embryos all can be reduced. And this is something which is given long protocol. Then this antagonist, the previous slide, please. Previous slide.
Sahiti, model slide போடு. Previous slide.
Yeah, here you can see on the right side, there is a long or desensitization protocol. Then again, it is the short flare protocol and the ultra short protocol. Okay, next slide, please. Next slide. Yeah, this is again our typical antagonist protocol. Next slide. Next slide. And natural or minimal stimulation. Earlier we discussed about it. Here there is something like if you do clomiphene right from the day 2, you can continue it till day 10, and you don't even require the antagonist to prevent the LHZ. CC itself will look after it, and you can trigger it once the follicle size is quite good enough, optimum. Then another thing is double stimulation. I think Pungoday madam, you can again explain this because you are familiar with it.
Yes, sir.
And last time we discussed in detail.
The-
Dr. Pungoday, you are there?
Yes, sir, I'm here. Am I audible,
Yeah,
sir?
yeah,
Hello?
audible. Kindly summarize about the double stimulation or
In
dual
the
stimulation.
in dual stimulation, we start in the follicular phase. Day 2, the gonadotrophin 225 to 300 international units of SMG. And it's continued. And on day 6, stimulation day 6, we add antagon. And we give trigger, an agonist trigger is given, and we do oocyte pickup. And after 3 to 4 days, or we can start again stimulation in the luteal phase. Again, the same protocol can be followed. Gonadotrophin and antagonist. And once trigger is get here, we can give HCG trigger 36 hours before pickup. Then second pickup is done. And here we can now do fresh transfer. We freeze all the embryos.
Yeah, basically the concept is that we have to do the freeze-all cycle. And this concept is very good because in the second stimulation in the same cycle, as per the literatures, that gives more better oocytes and more better embryos, more good quality embryos, which reach up to the blastocyst, and even PGTA can be done. And earlier concept was initially agonist trigger only to be given, but we can even give the HCG trigger in the initial trigger itself, and the that long-lasting effect of the HCG also will be useful for the stimulation during the next cycle. And this is something like delayed start protocol with the GnRH antagonist in poor responders. Where next slide, please. Instead of pre-cycle treatment, it can be GnRH can be given in the beginning of the cycle. So here you can see the estrogen priming, then along with the menstruation, GnRH antagonist on cycle day 7 to 9, start with the gonadotropins, and once the follicles reaches 14 millimeter, give the antagonist. This is one thing actually why I have shown this because very often the patients who are working in abroad, which we generally come across, working in abroad, we might have asked them to come on day 2 of the menstrual cycle. They may not be able to reach here. They may from UK, US, or the Middle East, they may come back on 6th or 7th day of the cycle. So what we can advise them, you can just prescribe antagonist. They can start antagonist taking, and once they are here, they can stop the antagonist and start stimulation. This I found to be very useful in such patients who just come here on the day of, just come here for stimulation and pick up alone, not for any previous cycle. And the time available also will be restricted. And these are the adjuvants. So I would like to ask anyone can answer regarding the adjuvant, basically the growth hormone, how to use growth hormone, when to use. Yeah, please.
Yes, ma'am.
Yeah, how to use growth hormone and how often and the dosage. Basically, growth hormone can be started on along with the stimulation on day 2, and 4 units can be initiated, and that can be continued till the day of trigger. And see, as per the SA guidelines, none of these adjuvants have the strong evidence, but the growth hormone alone is having some conditional evidences in this regard, apart from aspirin. Aspirin, of course, it is there approved for everything. Next slide, please. So this is the ISAR recommendation just for you to refer for all the audience. You can just look at it. What all things you can do, what all things you have to do in evaluation, in the dosage decision, trigger, and in the luteal phase. Next slide. Next slide, please. This is based on the AMH levels. Based on the AMH levels, you can again, but generally it is not recommended to go only on the basis of AMH because of the variability, but consider AMH and FC, consider age as the denominator. And also keep in mind the BFI of the BMI of the patient, because the obese patients will require more gonadotropins. Next slide, please. So this is something called a dual trigger. Dual trigger in the poor responders, that's said to be good effective. So, so do you all give single trigger against HCG or dual trigger? Who are all used to dual trigger? You can enlighten us.
Dual trigger I use for normo responders and poor responders, sir. For hyper responders, I use agonist.
Yeah, most of the latest studies, even a few days back, this 2025, one article has come. Dual trigger is not superior to agonist or HCG in normal responders, but it is cumulative live birth rate, and live birth rate is better in the poor responders. So obviously it is of use in the poor responders, and the efficacy is doubtful in the normal responders. But in practical experience, as you said, I also have seen more blastocysts are coming up in the dual triggers in the normal responders. So that can result in more cumulative pregnancy. Next slide, please. Yeah. So shall we discuss this case also? This is very short discussion. Sambat Kumari, madam?
10 minutes there, you can.
Yeah, this is ovarian stimulation in a breast cancer patient preparing for oncology treatment. So 32 years age, normal BMI, hormone receptor positive, invasive ductal carcinoma of the breast. Neoadjuvant chemotherapy followed by surgery and hormone therapy is planned. Regular cycles, no prior pregnancies. AMH is 2.1, and the AFC is 10, normal responder, and 7 analysis is normal. Next slide. Next slide, please. This how to balance the effective stimulation without harming the malignancy state. Safest and most effective should be opt for oocyte freezing or embryo freezing, or how quickly can stimulation be initiated. Next slide, please. Next slide.
Sahiti, next slide.
Yes, ma'am.
Somebody stop the presentation.
What happened?
Net is
next
somewhat
slide.
slow,
So
ma'am.
the choice of ovarian
second.
stimulation protocol, letrozole or antagonist, random start, use of agonist. Shaista, can you enlighten us?
So we can start with the letrozole because in breast carcinomas, estrogen exposure can lead to the flare-up. So it reduces the exposure will maintain it adequate follicular response is maintained. So we can give the letrozole first.
Yeah. Next slide, please. So it is something like this is the patient status, cancer diagnosis or surgery, conventional IVF that will take a month, chemotherapy, radiation. But for many solid tumors, including breast cancer, cancer diagnosis, urgent IVF, then followed by the neoadjuvant therapy. Next slide. Next slide, please. So that is one study, random start controlled ovarian stimulation for emergency patients. So here you can even zoom the slide and see the various types comparing to the conventional start. It can be conventional start or it can be the luteal start. Initial visit, GnRH antagonist, then withdrawal bleeding, then start with aromatase inhibitor, gonadotropins, add antagonist, then oocyte retrieval. Late follicular phase, then after the initial visit, it is in the late follicular phase that will be mostly just before the spontaneous surge, straight away start. So you are depending on the second wave of the follicles. No, why are you changing the slides without me telling?
I will go to the previous slide. Model slide go.
I have not even completed it.
Yes.
Yeah. Then you look at the lowest one, that is the luteal phase start. So whatever it is, the idea of random start is to do the stimulation urgently. You need not expect the same level of follicular response in this one. That's why it is not being recommended in the general population. Depending on the follicular phase or luteal phase, you may have to give antagonist before starting the stimulation. So this is the concept of the random start stimulation. Next slide. So this is the luteal phase stimulation, which I already described. Next slide. Yeah, here again, the depending on the types, when the patient reports to you, it can be late luteal phase or in the early luteal phase. It can be the early follicular phase. Early follicular phase, it is almost same like our regular stimulation, but late follicular phase, sometimes in some patients, you have to give an HCG trigger, collapse the follicle, and then stimulate. Next slide. Next slide. And this is the summary. Next slide. Yeah, again, late follicular phase stimulation. This is the phase where I mentioned we are going to depend on the second wave of the follicles. Even in some cases where you have not done synchronization, you might have noticed this state of affair during your conventional stimulation. So the idea is not to give up. You can continue with the stimulation to depend on the second cohort of the follicle. Next slide. That is the efficacy and the comparative retrieval rate and the embryo formation rate. Next slide. It is almost comparable. Next slide. Next slide. Next slide. Yeah. Then again, double stimulation is another strategy which you can apply in the onco patients here. But always remember, letrozole has to be continued in the particular type of patient where there is hormone-sensitive breast ductal carcinoma, because it can aggravate its invasiveness by we are increasing the estradiol level. So it anti-estrogens has to be given. Next slide. Same thing which I told you earlier. Next slide. Next slide. Yeah. Aromatase inhibitors. Here, letrozole significantly suppresses the plasma estrogen level, and adding daily dosage of letrozole 2.5 milligram to 5 milligram daily can reduce the estrogen load and reduce the exposure of estrogens to the breast tissue. Next slide. Next slide. Next one. Yeah. So all these estrogen responsive cancers, you have to use the aromatase inhibitors along with stimulation like breast cancer, endometrial carcinoma, stromal cell, and for the same SLEs. Next slide. Yeah. This is the actual regime where you have to use letrozole, because you start letrozole earlier, then stimulation, recombinant FSH, then antagonist, then trigger. So that is the serial order. Next slide. And it has been found very effective, the use of aromatase inhibitors in this random protocols for onco patients. Next slide. Next slide. Next one. Yeah, again, conclusions regarding women with breast cancer who received tamoxifen during stimulation could not be made due to insufficient data. Peak estradiol concentrations were suppressed by letrozole when commenced on day 2 or day 3. Here, actually, day 2 means day 2 of the stimulation. See, as soon as the patient comes, irrespective of the cycle day, you can start with letrozole for a few days, for example, 5 days. Then only start with the stimulation. Next slide. Next one. Yeah, you can stop sharing. So I would like to mention the concluding remarks. So basically, so there is little bit of discordance between the slides and my talk. Sorry for that. That is because I'm not able to share from my side. But to summarize, a regular ovulation induction is indicated in normally ovulating patient as well, especially if you are advising them IUIs. Availability of more follicles increase the chance of pregnancy. So all IUI cycles should be aligned with ovarian stimulation. Second, specifically, you have to individualize the protocol for in all 3 classes of the anovulatory cycles, class 1 and 2. And thirdly, ovarian stimulation can be very well done by a random protocol for the patients who are coming for the fertility preservation. Poor responders are always a challenge. Consider all the options, including dual stimulation and the progesterone prime stimulation. And poor responders and aged patients, consider PGT-A also as an option, because these patients' aneuploidy percentage is higher. So these are the take-home messages I would like to convey. I request Dr. Pungode, who is also an expert in the panel discussion, to say a few words and conclude.
Good evening. I would like to thank Dr. Sampath Kumari Madam for the opportunity to be a part of this scientific program. It was an excellent panel discussion moderated by our sir, Dr. Kunjumaitin. We learned many new points, including the random start protocol and ovarian stimulation in onco patients.
Yeah, thank you. Thank you, Dr. Sampath Kumari ma'am, for the wonderful opportunity. Best wishes for a grand success as well.
Thank you, Kunjumaitin sir. You are busy, you are discussing the panel, wonderful panel. I think what happened to the remaining 4 panelists, I don't know. They are missing cases, good cases. Thank you so much. Yes.
Thank you, ma'am. Thank you.
Thank you,
Thank you, ma'am.
Then
Thank
go
you,
to
sir.
the
Thank you.
Thank you.
panelist, Dr. Shisha, Dr. Vidya, Dr. Poongode, madam. You have filled up 9 panelists to 3 panelists and wonderful discussion. Yes, Dr.
Thank
Meena,
you, madam.
go with the vote of thanks. Dr. Manju, madam, is done. Unmute.
Thank you.
Yes, ma'am. As we come to the conclusion of this enlightening Pinnacle webinar series, webinar, it is my privilege to extend a heartfelt vote of thanks to all those who made this session a great success. First and foremost, I express my deepest gratitude to Sampath Kumari Madam for sharing her invaluable insights and setting the tone for today's discussion. Your expertise and dedication has made us all come here and discuss on the important topics of IUI and ovarian stimulation. Thanks to all our distinguished speakers, moderators, experts, and panelists. Today's panel discussion was amazing, and we had so many important take home messages. And one of the important things, like late follicular phase stimulation and luteal phase stimulation, we really need to work on this and add to our clinical practice also. Thank you for the participants for your engagement and the questions. And I appreciate the organizing team and technical support from Shield Pharma and host organization and all the supporting societies which are today part of this webinar. I express my gratitude. I express my gratitude to everyone who is present and who has listened this webinar. And also I would like to uh, invite, like, tell all the uh, people who should listen to YouTube presentation of this webinar also, because there are so many important topics which are discussed. And let's continue our commitment to this noble cause. And thank you, and have a wonderful day ahead. Thank you, ma'am.
Thank you, Dr. Bade, madam, and all the delegates, Vidya, Papa, Madhumita. Thank you. This series
Thank you, madam.
every month, second Thursday and fourth Thursday, 4:30 to 6. Second Thursday will be obstetric, fourth will be gynae.